ورجعت لكم في حلقة جديدة مع برنامجنا بودكاست بالسكر. معايا أستاذي أستاذ الدكتور رياز مالك، أستاذ السكر في جامعة وايل كورنل في الدوحة وقبلها في مانشستر، وهيكلمنا النهاردة على أحدث المستجدات في عالم السكر. احنا بنقابلته هنا في مؤتمر الجمعية الأوروبية للسكر في مدريد سنة 2024. Good morning, Professor.
السلام عليكم. Good morning.
عليكم السلام. Would you like to...
صباح الخير.
صباح الفل. Would you like to introduce yourself, please?
Yes, so I'm Riyaz Malik. I'm professor of medicine at the Weill Cornell, medicine in Doha, Qatar, and in New York, and also still honorary professor of medicine in Manchester University.
Okay. And what would you like to talk to us about today?
Okay, so, you know, I repeat again, I am professor of medicine, right? So I'm not a quack who's going to try and sell you something which hasn't got an evidence base behind it, right? And what am I going to tell you? I'm going to tell you something crazy, right? I'm going to tell you that I can, or we should be thinking about curing people with type 2 diabetes. That is, their diabetes disappears. And you may have come across people who say, take this herb, take that herb.
So it's just good
You
to
know,
tell you, okay, we can always cure diabetes. If you take two teaspoonfuls of cumin with whatever,
Yeah.
and before the sun rises.
Yeah.
Must be before the sun rises. Okay.
and you do dua. and-
Yes,
Yeah.
yes, and you have to pray, and
Yeah.
then the diabetes will suddenly fly out of the window.
Okay. So that to me is biologically and medically impossible.
Mhm.
Okay. However, there is now a whole new, honestly, it's a revolution. And the revolution is based around the new therapies that we have currently available, which are predominantly for weight loss. But we know that the majority of people with type 2 diabetes, weight is a major issue. And if you lose that weight, the evidence is now that if you have pre-diabetes, you can 95% of people will go into normal non-diabetic condition. And even if you have diabetes, 50-60% of people will go into the normal glucose tolerance. Now you could argue, is that a cure? Is it remission? I would say it's remission, right? It's not complete cure because it's always going to be there. The risk is always going to be there, but it is possible to become non-diabetic.
So if you lose the weight, you
Yes.
lose the disease.
Correct.
And if you get the weight back, you get the disease back.
No, no magic trick.
Okay.
This is fundamental
Makes absolute
physiology.
sense. I believe Roy Taylor
Yeah.
proved that. I think he's the first one who actually did it. Okay.
Yeah.
He proved that it depends on the amount of fat you have in your liver, when you get, which causes the insulin resistance, and the amount of fat you have in your pancreas, which is toxic to the pancreas. And at the end of the day, when you lose this fat, you lose most of its effect, as long as the diabetes hasn't been there for too long. So there has been too much damage.
Yeah.
Okay. Would you agree to this?
I would agree to this, and I think what I call their studies, their data is proof of principle that it can work, but is it practical?
It's
An
pretty-
800 kilocalorie diet is impossible,
It's
Hany,
impossible.
to maintain,
It's
and that's the
impossible.
problem. Which is why I think we are human beings, and I always say human beings who've got to the age of 50 and they've developed, or 40 and they develop type 2 diabetes, have been on that journey for 20-30 years. Okay, and it's very difficult to switch that journey off. So we need help, right? And actually, so low calorie diets, very low calorie diets, VLCDs, work, not for the long term. What was the real game changer was even 20 years ago when people underwent bariatric surgery. Okay,
Yeah.
which bariatric surgery is surgery that alters the way that our stomach is the shape
Would
and size
you
of our stomach.
say bariatric surgery is a cure for diabetes in people, in chosen patients who have the correct criteria?
Yes.
Okay.
Again, is it a cure or remission? I think it's remission, because we know that even in bariatric surgery, initially you have 90% plus people with diabetes disappears. But 10 years later, you look and 30% have got diabetes again. Why? Because they've gained weight.
Mhm. Okay, and that's why the bypass works better than the sleeve gastrectomy.
Correct. Because it has two mechanisms, you could say. One, it restricts the amount you eat. It makes you feel uncomfortable, right? And two, actually, it bypasses
Mhm.
the absorption of glucose and nutrients.
Does it cause a hormonal change?
Hormonal change.
I'm talking about GLP-1
Oh,
increasing.
yes. So there is some data to say, actually, that it increases the release of GLP-1 because you have this nutrient load that isn't absorbed, but is further down in the kind of ileum bit. It hits the ileum and it causes increase. Some people claim up to 20-fold increase in endogenous GLP-1. And of course, GLP-1 is what I'm talking about.
Which is the same drug which is present, so the same hormone which is present in the injections for diabetes
Correct.
people use in order to lose weight.
Correct. So for those of us who say, oh, it's a drug, actually, this is natural. This is a protein, a peptide our body produces, which, yes, Big Pharma has managed to find the sequence and they've produced it, right? So, but it is still a natural thing.
Okay, now that's another very good, valid point. So we can either use the drug, we can use the diet, which is impossible to maintain, in my opinion, at least.
Yeah.
Okay. By the way, we're talking about going through the whole day with 2 cups of shakes. Okay, so it's 2 drinks and a plate of salad.
Yeah.
Okay,
Exactly.
this is basically the diet we're talking about, and you're supposed to live like this for the rest of your life, which I believe is absolutely impossible.
And I would agree with you. And as you can see, I pretty much look after myself, and even I find it difficult. So, Hany,
Impossible.
I'm not sure.
Okay, so next thing I wanted to ask you about. So we said drugs. Oh, I also have a very valid question, which even I don't know the answer for. If I'm taking GLP-1, which is the injection for
Yeah.
obesity, for diabetes used for obesity, and my hemoglobin A1C has gone down to less than 5.8 or even less than 5.
Yes.
Okay, which is totally diabetes free. Yet I'm still using the injection, and the injection is a very potent anti-diabetic.
Yes.
Okay, have I been cured or in remission from diabetes? I'm still using the injection. So by definition, what is it? I really don't know.
Okay. So actually, there is American Diabetes Association guidance on this. So what they say is that you need to be off all diabetes medication for a minimum of 3 months initially, but at least 12 months. And some people argue up to 5 years, but I think 12 months without medication and your HbA1c is still below 6.5%.
Okay.
You are non-diabetic. You are
Okay.
cured.
So, but I'm still using the drug in order to maintain my weight.
But you have to stop it.
But if I stop it, I'll rebound. I'll regain all the weight that I
Yes.
have lost.
So about 30% of people will rebound at least. That is, and then again, it's not, rocket science. On drug, your appetite is reduced. You eat less food, you lose weight, or you maintain your weight. Off drug, of course, those urges will come back, and you will start to eat. So so I would say that if you lose enough weight though, and I think that's the key difference now. The earlier drugs you lost 5 kilograms, then 10 kilograms, then 20 kilograms. Now the newer triple agonists, you're losing 30 plus kilograms. That is really where you're in that ballpark where you are going to make a difference. You are going to really cure diabetes.
Okay. Now, next thing I wanted to ask you about was the importance of giving routine vitamin B12, as you are professor of diabetic neuropathy and you are definitely the best I know. Okay. What's the role of using B12 in diabetics?
Okay, so we know that if you're B12 deficient, you should give B12, particularly if you're on metformin. There are data saying that maybe 30%, 40% of people who've been on metformin for more than 3 years maybe become B12 deficient, and those people should be treated. And we know that it has a link with neuropathy.
Okay.
Now,
So
until
B12, low B12 or
Yeah.
deficient B12 causes neuropathy.
Yeah.
So, okay. If it's not there, I mean, there is no B12 deficiency.
Yes.
Which is, you've been working in Doha for quite a bit.
Yes.
How many B12 deficient people have you seen?
Well, not many actually, I would say.
How many per month?
Once,
Twice?
maybe once. Yeah.
1 or 2
real
per
ones.
month.
Real ones, yeah.
Yes. So basically, it's non-existent, as unlike Europeans.
Yeah.
Okay. First, we have very low levels of celiac disease. We have very low levels of inflammatory bowel disease. We don't have the problems Europeans have.
Yeah.
In the first place, to a greater extent.
Yeah.
We still have these diseases, but they're not that
Yeah.
common. And on the other hand, our diet is very rich in B12.
Yeah.
Okay.
Yeah.
So basically, if you can't get it from your diet,
Yeah.
okay, you will definitely need it through injections, because like a tablet won't do anything.
Middle East for sure. I mean, of course, India is a different picture where you've got diet. People who are vegetarian.
Mhm.
They
Yes, but Middle East,
yeah, we have plenty of kebabs, plenty of meat. Yeah.
yeah, even the yeast and the bread,
Yes.
the tomatoes, we're
Yes.
getting it through so many places.
Yeah.
Anyway, so people come to me, why aren't you giving me a treatment for neuropathy?
Yeah.
What should I say? I'm asking the expert, like the international
Okay.
top authority expert.
Okay.
Please answer.
So bottom line is, honestly, B vitamins, there's an incredible amount of science actually showing that they are good for nerves, right? But is that sufficient evidence to say that I should be treating people with B vitamins, B1, B6, B12, right? Which is the B vitamins. The evidence is not there yet, apart from one study I have seen from Greece, which showed over a year, just giving B12, even in people who had actually pretty normal B12 levels, I would say, but on the low side, right? About 250. Okay.
Okay.
Yes. Actually, over 12 months, symptoms were better.
Talking about 250. My country, we set the normal at 450.
Oh,
so
okay.
Basically, we treat anyone who's under 450.
Okay. So but I would say, the cutoff for some people is even lower to get truly
150.
B12 deficient, right? So and they went up to 700, and actually their nerve conductions improved, their symptoms improved.
This makes sense, being 250 and going to 700. Well, okay,
It's not dangerous.
I know, but my main problem is most people I get are over 2,000, because this is as far as the device goes.
Yeah, that's just that. I think that is excessive. Yeah,
Okay.
and we see that. I see that in my clinic, because they've been to see Dr. X, who says, yes, of course, I'm going to give you this B vitamins, which are going to repair your nerves.
Do they repair the nerves? Straight question, straight answer.
Okay, limited data.
Well, this is basically not saying anything.
No, honestly, I would have said to you before, this is all, there's no real science behind it, but there is now some science coming through that does show that B vitamins could be having a effect on nerves.
Would you call it major?
No, not
Is
yet.
it for anyone?
No.
So is it for everyone?
Absolutely no.
Absolutely. Thank you. Okay, so it's only reserved when you actually do have a deficiency, which means we should test.
Yes.
Okay, so we should test our patients for B12 levels before actually giving the drug.
Yeah.
This is rocket science in my country.
Okay. Really?
Yes.
Oh, well. Okay.
Yes, absolutely.
Huh.
It's B12 for everyone.
Wow.
Okay, one more thing I wanted to ask you about. We were just talking.
Sorry. Let me just. And you know what the best way to give B12 is? Of course, in your country,
Injection.
you have to give injection.
Yes.
Because it's more powerful.
Yeah, and you know what? The more painful the injection is, the more placebo effect it has.
Yes, of course.
B12
Thank you, doctor.
injections are very painful.
Yeah. Thank you, doctor.
Okay.
Yeah. And if you don't give it, they say you're not a proper doctor.
No, this is exactly what I was asking you.
Yeah.
Exactly. Okay, one last thing before just before we started recording, I was telling you about I was talking to the guideline committee who put the guidelines for NASH and diabetes and obesity.
Yes.
Okay, fatty liver and diabetes and obesity.
Yeah.
And I was asking them, should I screen, giving the difference in the major difference in price between doing a fibroscan and the ultrasound
Mhm.
in my country compared to anywhere else, were much cheaper. Okay, we're talking about something between $10-$20.
Yeah.
You can actually get a fibroscan and an ultrasound easy.
Yeah.
Okay, and taking out the cost factor, they answered me. They said, "Well, you're very lucky because in our countries we're talking about more or less 20-30 times the cost."
Yeah.
And even more. And they said, "Well, if you have this tool, why don't you use it?" What would you say to something like this?
I would say, if you have this tool, why wouldn't you use it? You know, I think if the cost is that much, then it is important that we do look for this condition, right? Because, you know, we know that it's, you know, having fatty liver, of course, long term, it can have potentially really bad effects in terms of liver fibrosis, cirrhosis. But even in the short term, actually, it's now being linked to the complications. So it tells you about the health of the patient. If you've got fatty liver, it's not good for you. And now we have medications that I talked about, the GLP-1s and the GIP-1, which actually melt away this fat, right? So you could do something about it.
So
SGLT2 inhibitors do it as well.
yes,
Yes.
it was also said in the symposium,
Yeah.
the NASH symposium. I wanted to ask you, in your opinion, is the problem of fatty liver a problem of the liver?
It's a problem of the fat in the liver.
Yes. And so is the problem confined to the liver?
No. If you have fat in the liver, it just tells you that you got fat in other bits of your abdomen. So things like, you know, we talked about this pancreatic fat.
Yes.
This is what we call visceral fat. So, you know, the problem with our people from our part of the world actually is we hide our fat inside rather than outside, which is what the Caucasian, you know, Caucasian, you see a big guy, you can see, oh yeah, you say he's fat. But ours, they look okay, but inside we're hiding this terrible, it's actually what's called the visceral fat, which is the bad fat.
And what does this fat do?
Basically, it is a horrible poison almost. It sits there and it produces all these, what we call cytokines, which are basically poisons. And they go and they damage tissue. Everywhere in the body. Everything from blood vessels to nerves to the kidneys to the eyes, everything. There's a relationship. The heart, of course.
Heart failure.
Of course. Well, heart failure, yeah. Okay, maybe yes. But you get this fat around the heart as well.
The epicardial adipose tissue.
Yes.
You know, I've actually done some work on epicardial adipose tissue and global, what is it called? GLS. Which is the first sign of heart failure.
Okay.
You can get on echocardiography before the patient has anything. We did some work on it, and they ran very synonymous. And the very strange thing we found, people who actually had symptoms, had chest pain, when we started them on a GLP-1, okay, which is these injections for diabetes, which reduce weight, they started to lose their chest pain on minimal exertion, and it was so we had this case series 7 or 8. We never published it. Okay, we had an 8-patient case series. For us, it was very strange.
No, well, you know, we know that if people lose weight, they are gonna get vascular health.
They didn't lose weight.
They didn't. Okay.
Immediately after starting.
Immediately after. Okay. Well, maybe there's some other mechanism.
I know there is many GLP-1 receptors in this epicardial adipose tissue.
Yeah, and on the myocardium as well, on the heart. So we don't know. There's much needs to be learned, you know. But you know, the saying is that for every illness there is a cure.
Yes.
And I believe we're at a time where type 2 diabetes as an illness is something that, if we believe that just because you've got type 2 diabetes, you've got it for life, we're wrong. We now have the ability to be able to cure or certainly remit type 2 diabetes.
Hopefully cure in the future.
Inshallah.
Hopefully. Before I leave you, because this is like a golden once in a lifetime opportunity, I managed to get you on camera. I wanted to ask you about something else. What was it I wanted to ask you about? It was something pretty important.
Which football team I support?
No, nothing in that there.
Manchester United, not Liverpool. But I do like Mohamed Salah.
That man has really changed a lot of things.
He tortured us in the last game, but you know what? He has changed perception of the Middle East, of Egyptians.
Yes, he definitely has.
You know?
Definitely has.
Yeah.
Okay, there was one thing which I really wanted to ask you, and that I totally forgot what it is. Okay, we did the GLP-1s, we did fat, we did SGLT2s, we did diabetes, we did vitamin D, we did bariatric surgery.
Vitamin D, did we do it? No.
Vitamin D,
but you're going to get Osman to do it. That's fine.
And what else? We talked about NASH, we talked about CCM. Can't remember. I really can't remember.
Spinal cord stimulators?
No, this is science
else.
fiction.
Yeah.
This is science fiction.
But it's coming. I'm telling you, it's coming. For those people who are refractory, it is something we should think about.
Do you think that someday people will actually go and have these horrible spinal operations?
Better than having a horrible life. And I've got examples of patients who said to me personally, their painful diabetic retinopathy is so bad, amputate my legs. That's how bad it can be in a small minority of patients. And it's those kind of patients, actually, I think, where spinal cord stimulators, if you look at the evidence, the pain, the average drugs that we use, duloxetines, pregabalins, gabapentins, what do? They reduce pain by about 50%, half, in about 40% of people. Yes. So, and then if you increase the dose anymore, they have side effects, particularly in this part of the world, right? So when you have that, so that's a score going from, say, 7 or 8 to 5.
Okay.
Spinal cord stimulators, 7 or 8 down to 1.5, 1.
But what about spinal cord injection and all this pain therapy?
No. Spinal cord injection is only for radicular pain if you have a disc or something like that, right? It is not for peripheral neuropathy. So all these other approaches, peripheral neuropathy, has to be stimulation of that area.
Okay, and by this we have reached the end of our episode today. We first talked about the diabetes remission, which is reversal of diabetes, and through various methods. We then went into vitamin B,
vitamin B12,
B's, generally speaking, and you have to actually measure it before starting it.
Yeah.
And then we talked about NASH, and we went a bit through how to detect it, and then at the end we went first we went through Muhammad Salah and how he made the big problem with Manchester United. How he leaving a lot of very, very sad.
It just shows you, I am objective. I'm not emotional. And just because he beat us, I still respect him.
Okay. And then the last thing we talked about was spinal cord stimulation for pain. And this is the end of our episode. And I'm very happy to have you, Professor.
Shukran.
Thank you.
Thank you,
Hani.
Thank you.
Thank you. Bye-bye.